Welcome back to the third and final video for this flipped classroom, coming full circle, what to do about thrombophilias during pregnancy. In this video, as we did in the previous video, using case presentations, we will touch on various aspects, including anticoagulation dosing, preparation for labor and delivery, and anticoagulation in the postpartum period. So let's go to our first case. Your patient is a 32-year-old gravida 2 para 1 at approximately 6 weeks gestation, presenting for her initial prenatal appointment. A viable pregnancy has not been confirmed with ultrasound. She is known to be a factor V Leiden heterozygote with a history of a deep vein thrombosis 2 years prior. Her last pregnancy was uneventful and occurred before she experienced a clot. Her family history is unremarkable. So as we did in the previous video, let's start answering some important questions. Well, is this a low or high risk thrombophilia? Well, we know that factor V Leiden heterozygosity is a low risk thrombophilia. Is there a family history? No, there doesn't appear to be. What is her risk of thrombosis during the current pregnancy? Well, we can go to the ACOG practice bulletin table and see that with a history of a clot, the risk of thrombosis in the current pregnancy is approximately 10%. This is somewhat significant. With this risk, she would be a candidate for anticoagulation. Plus, we know that with a low-risk thrombophilia and a history of thrombosis, anticoagulation during pregnancy is warranted. Now let's go on to answer a few more questions. What agent would you choose, and what is the dosing? When would you initiate anticoagulation, and is it necessary to follow any levels? Well, low molecular weight heparin would be the first choice. Now, what about dosing? This is a table from a nice article that came out recently from the folks that were in part responsible for the CHEST guidelines. I have included it for you. It is very comprehensive and lists the recommendations from various societies, including ACOG and Canada. You can see if you skim through the article that even among the different organizations, there is not a consensus regarding dosing of anticoagulation. Now, most would recommend a standard prophylactic dose of low molecular weight heparin of 40 milligrams daily. You will notice that intermediate dosing of low molecular weight heparin regimens are also listed. This is where it gets tricky and subjectivity comes into play. For example, someone might consider intermediate dosing rather than prophylactic dosing for a very high BMI or a strong family history. Of course, there may be some subjectivity about what constitutes a strong family history. Still, there are no definitive guidelines to say when prophylactic versus intermediate dosing should be used. In fact, there is an ongoing randomized clinical trial comparing prophylactic versus intermediate dosing to prevent recurrent thromboembolism during pregnancy. I would use 40 milligrams a day of enoxaparin, which is Lovenox. In terms of when you would start anticoagulation, I like to start it in the pregnancy as early as possible, as the risk of thrombosis exists in the first trimester almost equally when compared to the other trimesters. I typically confirm a viable pregnancy with ultrasound first. You can always initiate anticoagulation once there is a positive pregnancy test. Personally, I like to document a pregnancy with ultrasound because if there is a miscarriage, some patients may feel that the anticoagulation was responsible, even though in most cases that is unlikely. Is there a need to follow any levels? Well, with low molecular weight heparin and prophylactic dosing, there is almost no need to follow what is called an anti-factor Xa level, which is also known as a heparin level. I would like to add that for all my patients who receive anticoagulation during pregnancy, whether it is prophylactic or therapeutic dosing, I like to add supplemental calcium at 1,000 to 1,200 milligrams a day due to the risk of osteoporosis. And any calcium supplement is fine. Let's look at another case. This patient is a 41-year-old gravida 1 para-0 with a history of 2 deep vein thrombosis and is known to be a homozygote for the factor V Leiden mutation. She is followed by her hematologist and has been taking warfarin. She has been interested in getting pregnant and is aware of the risks of warfarin between 6 and 12 weeks. She has a positive pregnancy test and has made an initial prenatal appointment with you. You may not be that excited about that, and you may just say, nope, not going to see her, send her right to the maternal fetal medicine physician. But let's pretend you're not going to do that. Any patient on lifelong anticoagulation will warrant anticoagulation in the antepartum period. This patient has a high-risk thrombophilia. Now, if she did not have a history of thrombosis and was only a factor V Leiden homozygote, depending upon her family history, she would be a candidate for prophylaxis in both the antepartum and postpartum period. Some might use intermediate dosing, again illustrating there is no absolute consensus on this. With her history of thrombosis and a high-risk thrombophilia, she would be a candidate for therapeutic anticoagulation. Now, what about dosing? Again, this table is from the same article we discussed. It is standard to use 1 milligram per kilogram BID for therapeutic anticoagulation with low molecular weight heparin. Some consider using once-a-day dosing, particularly for the patient who would not be compliant with twice-a-day dosing. But with low molecular weight heparin being cleared by the kidney and with increased renal clearance during pregnancy, I recommend BID dosing. And the anticoagulation can be started once viability is confirmed. Now, I sometimes get asked about the need for following anti-factor Xa levels, also known as heparin levels, in those patients who are receiving therapeutic anticoagulation with low molecular weight heparin. Well, low molecular weight heparin has a predictable response, and it is not common to need to adjust the dose during pregnancy. Current guidelines do not mandate routine monitoring of anti-factor Xa levels. Now, anti-factor Xa monitoring may be helpful to ensure appropriate anticoagulant effect in patients with renal impairment and in those at the extremes of body weight. I've seen some providers follow anti-factor Xa levels monthly. I think this is overkill. I will usually check 1 or maybe 2 levels at most during the pregnancy. I sometimes get a level about a week or 2 after I initiate anticoagulation, and maybe one more 1 or 2 months later, and even that might be overkill. Now, I would say that if you are questioning compliance with the BID injections, then obtaining an anti-factor Xa level is reasonable. The target goal is 0.6 to 1 units per ml. Now, what about management in the peripartum period? Well, the answer depends upon whether you are using prophylactic versus therapeutic dosing. Now remember, the real concern here is not bleeding during labor, but rather allowing the patient to be a candidate for regional anesthesia. For prophylactic dosing, a minimum of 12 hours should elapse prior to receiving regional anesthesia. Most hospitals or anesthesia units will have their own guidelines. I often will do 24 hours to be on the safe side. For therapeutic dosing, most recommend stopping anticoagulation 24 hours before an induction. The ACOG Practice Bulletin recommends stopping therapeutic anticoagulation 24 to 36 hours before an induction or a planned cesarean section. In the interest of time, I am not going to discuss the use of unfractionated heparin either in the antepartum or peripartum period. Of course, I would be happy to discuss this when we are at the annual meeting. Now, I would like to present two cases that illustrate how we don't need to urgently perform a thrombophilia workup in the midst of an acute event or during anticoagulation. Now, the risk of doing this is your patient could receive an incorrect diagnosis that may have lifelong implications. In addition, the workup usually will not affect your management, at least in the short term. So next case. Your patient is a 34-year-old gravida 3 para 1 who has a history of a pulmonary embolism diagnosed at 32 weeks gestation in her prior pregnancy. She initially received intravenous heparin, then therapeutic low molecular weight heparin until delivery. She was started on warfarin in the postpartum period, and this was continued for 6 months. She underwent thrombophilia screening around the same time she was diagnosed with a pulmonary embolism, and her antithrombin 3 level was found to be low. She was told she has an antithrombin 3 deficiency. She has no family history of thrombosis. Now, this table is from the ACOG Practice Bulletin and looks at the reliability of thrombophilia testing during pregnancy, during acute thrombosis, and with anticoagulation. So what is wrong with this picture? Well, first, usually, although not always, with such a thrombogenic thrombophilia as an antithrombin 3 deficiency, there is an extensive family history of thrombosis, particularly at ages prior to 50. This patient has an unremarkable family history. Now, more importantly, this antithrombin 3 level was likely drawn when the patient was receiving anticoagulation. You can see from this table that assessing for an antithrombin 3 deficiency is not reliable during an acute thrombotic event or when the patient is receiving anticoagulation. So, this patient would be a candidate for anticoagulation in the current pregnancy in light of her history, but it would be incorrect to label her as having an antithrombin 3 deficiency. I think it would be reasonable to repeat the antithrombin 3 level prior to initiating anticoagulation. Another case. Your patient is at 22 weeks gestation when she is diagnosed with a left-sided deep vein thrombosis. Therapeutic anticoagulation is initiated and a thrombophilia workup is performed. The free protein S antigen level is noted to be 43%, and the patient is diagnosed with a protein S deficiency. She is told this was the etiology of her thrombosis and that she is at very high risk of developing thrombosis in her lifetime. So let's talk briefly about protein S deficiency. Protein S levels decrease considerably during pregnancy, and testing is much more reliable in the non-pregnant state. Dr. Michael Paitis from Yale has established a level of 30% in the second trimester and 24% in the third trimester to use as a cutoff if one is considering diagnosing a protein S deficiency during pregnancy. In my experience, for all the consultations I have performed for a question of a protein S deficiency, all of them turned out not to have this condition. Please keep in mind that it is very unlikely that you will diagnose a true protein S deficiency. Again, you can see that protein S levels are not reliable during pregnancy, during acute thrombosis, or with anticoagulation. We previously discussed individualizing a thrombophilia workup rather than ordering many tests, some that have a low prevalence and may not be reliable. I would ask you to consider not ordering a protein S level during pregnancy unless there is a documented family history. This slide offers some tips about when to perform thrombophilia screening. If possible, I would urge restraint, as there is no need to urgently perform thrombophilia screening during an acute event, and it is highly unlikely it will affect your management. I would like to wrap up by highlighting some important points we have discussed in these videos. First, do not screen for the MTHFR mutation. That is clear from the ACOG practice bulletin. There is no proven association between adverse pregnancy outcomes and inherited thrombophilias. So although your patients may want you to do something, and you may as well, if appropriate, resist the urge to screen or treat. Remember, most of the thrombophilias are not common. Thus, consider tailoring the thrombophilia workup, perhaps only performing factor V Leiden and prothrombin gene mutation, the two DNA tests that are the most common and can be performed at any time. Thank you all for your attention, and I look forward to seeing all of you in Washington, D.C. in May.